this is I'll be focusing mostly on the short cases. So you would have know, all of you, I'm sure, very you are aware of the normal short cases radiographs. How many radiographs have been provided, and all those details are there in the RCR website. So I'll just want to reiterate those some facts. So 25 radiographs will be provided in 120 minutes. So that roughly translates into 4.8 minutes per case average. So all cases are abnormal. There will not be a normal films included in the exam, and it will be a written only, or typed computer-based typed reports you have to give. So it's not oral component is separate, or the viva is separate. Brief reports with key findings, diagnosis, and next management step are expected when you are reporting the short cases. And it is marked out of a total of 125 marks, and 5 marks per case max. So by 2 independent examiners. Thus, the exam content breakdown, modality-wise, you'll get around 50 to 60% of chest cases, and 40 to 50% of MSK, and around roughly 1 to 4% of abdomen. And age distribution wise, so adult around 75%, and pediatrics around 25%. This is how the overall scoring system looks like. So 4 to 5 is an excellent where you have picked up all the major findings, correct diagnosis, safer and clear management plans, and a logical approach. And score 3, safe pass, and score 0 to 2 is a concern. So where you have, if you are missing a critical finding, or an unsafe management, or a poor structure, or incoherent reports. Okay, so the golden rule is to describe, localize the pattern. You have to formulate a pattern, then move to the differential diagnosis, and you have to give an final diagnosis or an impression. So this structure has to be there in every single case and every time when you report, especially the short cases. So this is the I give you this 5-line report template. So it would be easier in the exam if you follow this pattern, where even if this is what the last line said. So the structure alone scores marks. So even if you are not sure of a diagnosis, so still this structural based pattern will fetch you some marks. So first is the first line of the report. Observe briefly, especially the key findings. Where is the lesion? What type of lesion are you dealing with, and how does it look like? Then you formulate a pattern where you have to give a radiological pattern that includes either is it a consolidation, is it a cavity, or is it a fracture line? Then once you have done that, then you should briefly give 2 to 3 diagnoses. Do not write more than 3 as a differential. You are just going to pile up unwanted diagnosis as your differential if you are going to keep more than 3. So mark any life-threatening findings as urgent. You have to flag this, very important. So you will definitely get good marks. And of course, you have to mention at the end of the report, you have to give the next imaging or the next plan. Either you will refer this case to an MDT or a clinical review meetings. So approximately aim for around 150 to 200 words. That's the maximum. And use always this bullet style phrases. Do not use like a clumped paragraph. Do not type like that. So time management, remember around it's a 25 cases in 120 minutes. So the first 1 to 5 cases, practice speed, don't overthink. So try and save at least 1 or 2 minutes in this first session. Then second session is 6 to 20. You have to keep that steady pace, use template, and you have to maintain that structure. And around again in 6 to 20, try and save some couple of minutes And the last session will be case 21 to 25. So use this bank time for some complex cases and do not rush into this phase. And if you are stuck, you have to definitely move on, flag those cases, and then you can return if time permits. So usually, if you save a couple of minutes in this one, in this session two, then session three, then you will definitely have some time for all those complex cases. So some of the critical mistakes to avoid while reporting short cases. Do not type the answers directly in the first line itself. You have to describe the findings first, and do not type a long paragraph or a phrase where bullet style is expected in the exam. And missing life-threatening findings, especially pneumothorax or air under diaphragm obstructions, these are all a very crucial part of your report. So you have to flag these life-threatening findings. Guessing rare diseases, especially in the exam, when most common pathologies usually the answer, or usually the common pathologies were given in the exam. So do not guess the rare diseases. And unsafe management suggestion, especially missing urgent referrals if there is a case of an aortic dissection in the radiograph, and you are supposed to refer this case urgently to the vascular surgeon. And inappropriate next steps, so suggesting a different step, so for a surgical plan rather than referring this case to MDT. So all this will not give you a good marks. So these are some of the high yield chest findings. So especially the pneumonia, you have to, if you see a pneumonia case, talk about the consolidation, lobar or segmental pattern. So describe about air bronchogrowth. And if you are seeing a pneumothorax, is it the apical tension signs? Is it a tension type of pneumothorax? And you have to describe the mediastinal shift pattern. Pleural effusion, blunting of costophrenic angles. You have to talk about the mediastinal shift. So, and also mediastinal widening in cases of malignancies. ILD patterns. So when you are given ILD patterns in the exam, you have to describe, is it a reticular pattern, nodular pattern, and associated ground glass opacities, and also is it an apicobasal gradient, or is it subpleural sparing? So all this you have to look at in the ILD type of pathologies. The lines and tubes, very important. Look for the position, especially the endotracheal tube, the nasogastric tube, and the central line tip. For musculoskeletal radiographs, look at the fractures. If there are fractures, alignment, you have to look at. Is there any negative or a positive ulnar variance? Very important to look at. Then dislocations, look at the shoulder, especially the anterior, posterior. If you are given a chest radiograph, so edge of the film findings will, that's the examiner's favorite, so don't miss out on that. And pediatric cases, Salter Harris type classifications, very important. Metaphyseal variants, and look for all this growth plate uh, uh, fractures. Subtle signs, especially those buccal fractures, stress fractures, and look at the fat pad signs for the joint effusions. Particularly, fat pad signs will be very crucial in if you are reading the elbow X-rays. Bone lesions, look at the age, location, matrix, is it lytic or sclerotic, and also periosteal reactions. So what to do when you do if you don't know the diagnosis? So describe exactly what you see and don't guess, and follow that pattern like we were discussing so far, and state it's pathological or abnormal. So yes, it is most of the all the cases that you get are going to be a pathological or an abnormal case, and offer a safe broad differential. Like I said, keep only 2 to 3 options. Don't go beyond 3 differentials. Suggest Further imaging, either a CT or an MR or an ultrasound or a clinical correlation. So if you don't know, never panic and never invent new or never type new words or new pathologies, and don't sound like an uncertain when you are especially when you are typing. So ill-defined opacity with hilar lymphadenopathy, most likely TB. So this is how you should proceed. It's a TB, fungal, bacterial pneumonia, or a malignancy. So recommend CT thorax for further characterization. I'll just give you an example. So what you see here, this is a plain radiograph, frontal radiograph of chest. What you see is a large cavitatory lesion with air fluid levels. Uh, Probably a thin-walled lesion. So I'm not seeing any associated axillary lymph nodes, no other cavitatory lesion. So in a 45-year-old with cough and fever, so this is how I will describe in a short case: thin-walled cavitatory lesion at the junction of upper and mid zone of right lung with air fluid level. Rest of the lung appears normal. So the cavitating lesion in the right upper lobe around 3 to 4 centimeter, no surrounding consolidation, hilar nodes. So my diagnosis is a lung abscess, and I'll differentials includes tuberculosis and malignancy. Plan urgent respiratory medicine review and antibiotics followed by drainage. So this is how you should roll this case. Very crisp, and it should be less than 150 words. So I give this 4 week pre-exam preparation at 4 weeks before the exam. So routinely see this at least 15 to 20 chest cases daily, and you have to see at least 10 MSK cases daily, 5 abdominal cases. Learn the patterns, how to approach, and what mistakes are you making. So how can you correct those mistakes from your own words? Prefer or write down the checklist. How if you see an abdominal X-ray, how I will approach. What are my checklists? Then at week 3, full time sets. So around 25 cases in 120 minutes. So you have to do this and self mark using a rubric or using your pen and pencils. Then week 2, time sets. At least you have to do 4 sets in week 2. So review every case, the goods and the bads, and especially are you following the time? That is very important. And just a week before exam, so at least complete these 2 full-time sessions, 25 sets each. And then, of course, take rest, and you should trust your preparation, and you should definitely manage anxiety. This may sound very silly to you, but at the exam time or when you're sitting in the exam, all these preparations will depend on this when you go for the exam. So remember, you have to be very calm, very unclutter your mind from all that, and then think through the cases, especially when you are in the exam hall. So of course, short cases are not about the rare diagnosis or a medical trivia. They test the systematic thinking, how well you approach the case, a clear communication, and a patient safety. So you have to master the template. So you have to trust your knowledge, and definitely your confidence will shine through the exam. So this is the first session. I'll just will go to the next session. So after this, I'll just give you a break for probably a 5 minute break, and then we'll resume the third session. All right. So the portable X-rays are a very key aspect. So sometimes you will get at least 1 or 2 cases, or at least 3 cases in the exams. So what are the benefits of portable X-rays? So it is cost effective, and it gives a satisfactory evaluation of patients who can't be transported due to their clinical condition, especially in the ICU setup. So apart from that, it helps in monitoring of stable patient or a patient on a mechanical ventilation in the ICU, especially if it is clinically indicated. And other benefits are after placement of endotracheal tube, whether to monitor the tube position, and central venous catheter, the pulmonary catheters or Swan-Ganz catheters, nasogastric tube, feeding the genostomy tubes or chest tubes. So for all the tube placements and the tip, whether the tip is in correct place, so we need to do a portable chest radiograph. Uh, so some of the goals and expectations in the portable chest radiographs are determined absence or presence of disease. It does give us the outflow, and especially in the medically unstable cases, and also helps in evaluating the life support devices, and also picks up the complications, especially post central line placement. If there is an associated apical pneumothorax, can be easily picked up in the portable chest radiograph. So these are some of the critical findings that you should not miss, or you should report when if you do see, especially the iatrogenic instrumentation, malpositioning of device, pericardial effusions, aortic dissections, pneumothorax, mediastinum, pneumoperitoneum, fractures and dislocations, especially involving the humerus in humerus and also ribs post CPR. So very important. Again, going back to some of the basics, some junctional lines. Uh, uh, Anterior junctional line, that's the line usually uh, the anterior junctional line is nothing but a small reflection of the parietal and visceral pleura. So you can see in the parietal and visceral pleura joints at the anteromedial aspect of the chest. So usually it gets displaced in the anterior mediastinal masses. The next one is the posterior junctional line. So again, that's the CT image for a correlation. Again, posterior junctional line, similar of just like the anterior junctional line, where there is visceral and parietal pleura joints along the posterior aspect of the mediastinum. So usually this line also gets displaced in posterior mediastinal masses or aortic pathologies. The third one is the paratracheal stripes. So there is right and left paratracheal stripes. So usually it gets thickened or displaced with lung neoplasm, or it gets effaced during pleural effusion, and also lymphadenopathy. The other line is the aortopulmonary stripe. So usually this stripe uh, is nothing but the interface of the pleural surface of anterior segment of left upper lobe contacting the mediastinal fat, which is actually anterolateral to the pulmonary trunk. So that's the stripe. So usually this gets effaced or elevated with mediastinal masses, lymphadenopathy, and also along if there is a pneumomediastinum. The other line is the uh, uh, right and left paraspinal lines. So you can actually see as the name suggests, along the spine. So this gets displaced with posterior mediastinal masses, or if there is any abnormal esophageal lesions. So, sorry. These lines has got very crucial roles. However, it is difficult to reproduce or evaluate, especially in critical care settings. So, especially in ICU setups, so patient positioning may not be correct, and there can be multiple overlying tubes and lines And of course, either an overexposed or an underexposed suboptimal technique can also lead to under evaluation of these lines and stripes in the ICU setups. So I give a small mnemonic, like how to approach, especially when for the uh, X-rays, especially when in the ICU setup. So C stands for chest, sorry. H stands for heart, E stands for endotracheal tube or lines and tubes, S stands for spine and soft tissue evaluation, and T stands for trauma and fractures. So this is C stands for chest, so where we evaluate the lung apices, the lung hilum, the bases, and also the pleura. So that's the C for chest. Usually these, you can actually appreciate a nice ill-defined opacity in the left apices. So look at the apices very carefully. Sometimes lesion in the apices can be missed. Again, similarly, look at the hilum also, especially the hilar nodes, or if there is any hilar pathology, you have to mention in your report. And of course, the lung bases or the adjacent to the paracardiac region. So again, this is an elusive area we call. Uh, you have to be very careful. And of course, pleural-based pathologies you have to mention in the report if there is any. Again, another example, H is for the heart. So look out for the cardiac margins. You have to be you have to outline the margin very well, and of course look at the retrocardiac spaces or the retrocardiac margins if there is any associated soft tissue lesions. So this was another case where there was a lower lobe pneumonia. Uh, Very subtle. It's quite dense here. Apart from that, we couldn't appreciate much. But on a CT, we can actually see a lower lobe pneumonia with a air bronchogram. E stands for endotracheal tube or lines and tube devices. So mm, you have to give a brief outline. What sort of tubes are placed? Is it endotracheal tube? And once you see the ETT, look at the placement. It has to be 2 centimeter above the carina. It should not reach the carina. Second is the nasogastric tube. Look where it is coursing. Is it into the distal stomach, or is it going into the lung parenchyma? So very important. Internal jugular vein catheters. Look at its tip. Where is it placed? Is it at the KO atrial junction, or is it going beyond the junction into the right atrium? So very important to mention. Once the tip is in the right atrium, patient are more prone for bradycardia. So a very important feature to note and intimate the ICU physicians. Nursing monitoring systems, and you have to wade through these EKG lines. Uh, S stands for the spine or soft tissues. So always remember to look at the midline spine and also look at the effacement or the progressive increase in decrease or increase in the spine density. So this was a case where there was the spinous process could not be visualized that clearly posterior to the trachea. So CT scan showing a large soft tissue lytic lesion, which is biopsy proven multiple myeloma. Again, look at the soft tissues. Air can hide in plain sight in soft tissues and also in the diaphragm with so many ECG leads. And if you look very carefully, you can actually appreciate a small line or air under diaphragm. You can appreciate in this case. So you have to be very cautious. while reporting or while seeing the plain radiographs. You should not miss the pneumoperitoneum, which can uh, definitely lower your score. T stands for trauma. The checklist includes this is the inverted images. So make sure you do this when even not only I'm not sure if this can be available in the exam, but at least in your real practice or in your routine practice, you should do this, especially while reporting the ICU X-rays or the portable chest radiographs. So look at the ribs, clavicles, humeral fractures, and shoulder dislocation. So you can actually appreciate there is discontinuity in the rib, and on inverted images, actually, you can see the fracture line here nicely. All right. So with this, probably we should is candidate one online? Can you
Um,
kindly unmute?
yeah. Good evening. Good evening. Hello.
Hi, good evening. You can take this case.
Yeah. So this is a case
So
of
yes, yeah. Oh,
this is a case of 60 years old male who was admitted to ICU for acute respiratory failure and COVID-19 pneumonia. So I'll just have a quick look over the radiograph and then I'll give my findings. Okay. So on I can see that there are multiple chest monitoring leads noted. Apart from this, I can see that there is a nasogastric tube noted with its tip going below the diaphragm. Possibly, I think it is seen into the gastric fundus. Also, I can see that there is a endotracheal tube noted with its tip at the left. I think it is above the carina, normally placed. And okay. I can see in the lungs, I can see that mm, there is a leucin. Okay, I just want to comment on the one more line I just noted before proceeding to the lung findings. I suspect that there is a central venous line noted as well. With its tip in the atriocaval junction, I think that this is coming from the left side. Probably there is a left-sided superior vena cava, and with its tip lying correctly at the atriocaval junction. Now I can see that there is a area of lucency lying in the lung, on the left in the left side of lung, with the passive collapse of the left lung. There is a pneumothorax noted, and with the with this is there is a flattening of the hemidiaphragm. So this is a left hemidiaphragm. So this is a tension pneumothorax, and this needs to be urgently informed to the on-call surgical team for urgent drainage of the pneumothorax. And I am also now I'm looking for the other findings. I can see that there is a area of lucency noted in just beneath the right hemidiaphragm. However, I can see that there are some with hostile markings, so I'm suspecting it to be most likely this is in keeping with Chilaiditi syndrome, and there is also a right-sided. There is blunting of the right costophrenic angle noted as well. So putting it all together, I'm also having a look at the bones. However, I'm not keeping it. Um, I'm not suspecting any bone injury because the history is of COVID, and I also noticed that there is a opacity noted. There is some soft tissue swelling also noted on the right side of hemithorax. Um, which I am really suspicious of. However, I'm not able to see any lucency in that soft tissue pasty along the right lateral chest wall. So putting it all together, in this patient who has presented to ICU with acute respiratory failure, I'm suspecting left-sided tension pneumothorax, which is an urgent finding and needs to be urgently informed to the on-call surgical team for urgent drainage of the pneumothorax.
Okay. So let me just give you the what do you call from my side. Let me describe it for the other candidates also, or for the other students. So you have started very well. I always prefer to tell this finding first, isn't it? The pneumothorax is more urgent and very important. So, and even in your typing report, when you are typing, you are supposed to type this one as first one, so that later these things can come later. The central lines and other things. So prioritize your the emergency situation. So same thing goes for the exam. And look at the heart shadow. You have not mentioned anything about the heart shadow, though. Slightly tubular kind of picture, isn't it?
Yes.
So, yes, apart from that, you have picked up the pleural effusion, that is blunting of right costophrenic angle. And the central line is, yes, there is a left-sided SVC. And the central line is in C2, and it is not going beyond the right atrium. And we can actually appreciate an abnormal opacity with hostrations. So this is a chilladity kind of pattern where there is like a large vowel loop is going above the uh, liver surface. So yes, that's the pneumothorax. You need to urgently inform the surgeon. We need to put a chest tube for this pneumothorax. Actually, you can actually see some air fluid part. I'm also not convinced, but yes, there is definitely a the pneumothorax with possible blunting is there, but pneumothorax is fair answer in this case. Okay, next case you can.
Okay, so this is a case of a 57 years old female who presented to ED with seizures. So I'm just having a look, then I'll give my findings. So the patient has presented with seizures, and I can see that there are multiple chest monitoring leads noted, and the bilateral lungs appear to be normal, and the hilar shadows, costophrenic angles appear normal. I'm not able to see any nodular opacities or patch of consolidation in the bilateral visualized lung. Now, what catches my eyes, since the patient has presented with seizures, I can see that the left humeral head is not well aligned with the glenoid cavity, and I can see that there is a I suspect that most likely this appears to be a posterior dislocation of the left humeral head, and the it is not maintaining a parallel alignment with the glenoid cavity, and this is also in keeping with light bulb sign on the left side. Apart from this, I'm also checking for any other bony pathologies. The right glenohumeral joint appears to be normal. Acromioclavicular joints appear to be normal. I'm also checking the ribs for any other uh, fractures which I'm not able to see. So putting it all together, I suspect that this patient who has presented with seizures, there is a posterior dislocation of the left humeral head, and I would convey my finding to the referring physician. The patient will also need an orthopedic referral, and since the patient has presented with seizures, imaging of the brain has to be performed, if not done already. Thank you.
Okay. So yes, pretty good description. So what you see here is internally rotated shoulder, and there's widening of the, sorry. Whitening of the glenohumeral joint, which is typical of a dislocation. And rest of the lung parenchyma appears normal. There is no other bony pathologies, and there is no other fractures. And yes, a patient needs a MR brain for the seizure evaluation. All right, so good description. So again, this is the classic typical light bulb sign that you get to see in the shoulder dislocation, especially the posterior shoulder dislocation you will get to see. And that's the CT, which demonstrates a reverse hill sac. So reverse hill sac is nothing but impaction fracture of the anteromedial aspect of humeral head following the posterior dislocation of humerus. So it is of a surgical importance, and otherwise the patient can go into osteonecrosis if it is not corrected immediately. All right. So this part also you should probably, if you mention in the report, it can definitely get you a high marks. Okay, so we'll move to the next candidate. So I'll give two more X-rays for the next candidate.
Hello, sir.
Hi.
Shall I start?
Yes, yes.
So the patient is presented with a complaint of 72-year-old male admitted in a ICU, developing worsening hypoxia. So I have been presented with a frontal radiograph of an SCLT mature patient. I'm looking through the image. So I can see that there is a nasogastric tube is noted. However, I could not find its distal tip. And there is also evidence of left-sided PICC line, peripherally injected catheter, which appears to be at a normal position. And there are multiple leads line are also projected over the chest. And there is evidence of air lucency noted outlining the border of the heart on the left and right side. Which is and also elevating the pleura. So this is suggestive of pneumomediastinum. And looking at the lungs, there is the evidence of a patchy alveolar opacity seen within the both lung field, which could be due to acute respiratory distress syndrome, as patient is admitted in an ICU. And there is also blunting of the left costopharyngeal angle, which is suggestive of pleural effusion. Looking at the bones appears normal. Cardiac outline appears normal. So in summary, this is a case of pneumomediastinum, and with the lung changes are suggestive of acute respiratory distress syndrome. So I will immediately convey my finding to the referring physician. On this patient require observation, and also this could be due to, as patient is ICU setting, this could be due to some pneumomediastinum can be due to some line insertion. So a patient should be kept under an observation and should be monitored carefully for this. And if there is any suspicions of esophageal rupture, so contrast-nasal CT scan can be done to evaluate further for this patient.
Okay. Let me. So what you see here, air along the cardiac lot. So if you look very carefully, there is a fine difference between pneumomediastinum versus pneumopericardium. So this is a case of a pneumopericardium. If you look, how do I differentiate between these two is very important. So pneumopericardium, you will see up to the aortic root. So beyond which the air cannot go, because that's where the pericardial space ends up. However, in pneumomediastinum, the air can dissect all the way up to the esophagus or along the paratracheal stripe. But in our case, it is not there. So only air is just limiting here. So along the aortic root, it is not going past. So this is a case of a pneumopericardium. And you have described about the opacities in the lung. Yes, there are bilateral ill-defined opacities in the lung, which is again in keeping with some infective, either a pulmonary edema pattern or some sort of an infection is also underlying infection is also possible. And yes, you have mentioned about the left CP angle or the costophrenic angle blunting in keeping with uh, a pleural effusion on the left side. Next case.
So the patient is presented with complaint of chest pain and 16 years old patient. So I have been presented with a frontal radiograph of an 16-year-old male patient who is presented with a complaint of chest pain. I'm looking through the radiograph. And also I can see that there is evidence of air lucency noted along the left paratracheal area. And there is also air lucency seen in the bilateral apices region. In my routine practice, I will zoom the image to see if there is any devoid of vascular marking. So I think I could not find a visceral pillar line at this area, but yes, the air lucency are seems to be extending along the neck region within the soft tissue of the neck. So this is suggestive of pneumomediastinum with a possibility of subcutaneous emphysema. Looking at the cardiac contour appears normal. I could see some thin line along the left mediastinum, which appears to be elevated and lined by lucency. So this is again in a favor of pneumomediastinum. Apart from that, the lungs appears to be normal. There is no any evidence of opacity or any mass lesion seen. The costophrenic angle appears normal. I'm looking at the bones. The bones grossly appears normal. No any evidence of fracture. So in summary, this is a case of pneumomediastinum. So I will convey my finding to the referring physician and inquire about the cause of the pneumomediastinum. If patient is present with a severe vomiting, so the contrast in CT scan of the patient can be done with oral contrast to rule out the esophageal injury, and patient should be monitored carefully for if there is any further extension of the pneumomediastinum.
Okay, yes, very good. So let me explain this case. So you can actually appreciate air along the superior mediastinum. So these patients sometimes, especially in young patients who is non-alcoholics, so these patients can have spontaneous rupture of esophagus, one of the high or causes for spontaneous pneumomediastinum. So you have to be very careful, and you should monitor these cases, and you should suggest further investigation in the form of CT. Other important differentials in this case includes a Macklin effect. I'm not sure if you all heard about that. So sometimes vigorous coughing can cause air to dissect from the pleura into the mediastinal space, and it can mimic like a pneumomediastinum. All right.
Yes.
So yes, so that's what I was talking about. So MAC effect versus pneumomediastinum versus pericardium. So it's this is a case where it mimics like some sort of pneumopericardium, but how do I differentiate between these two, MAC effect versus the real pneumopericardium? It usually it will be a thin line. However, in the again, pneumopericardium can also be thin line, but you will see this elevated pericardium where once the air dissects. So that sort of effect is absent, and of course, if you repeat these cases, these MAC effects can disappear in the repeated radiographs. Again, very dicey situation. Very difficult to differentiate between these two, especially the MAC effect versus pneumopericardium, and you need, of course, a strong clinical suspicion, and clinical history is also very important in these cases. All right. So we'll move to the next candidate. The next candidate can unmute and can take the case. Yes, I can hear you.
Perfect, great. This is a portable chest radiograph of a 65-year-old female presenting to ED with shortness of breath. I will review the film and make my comments. So I can see that the heart is enlarged. There appears to be slight splaying of the carina and loss of the left costophrenic angle in keeping with the pleural effusion. Looking at the lung parenchyma, I don't see any evidence of airspace opacity or interstitial edema, but I can see some upper lobe diversion of the vessel with prominence of the vessels in the upper zones. I cannot see any evidence of pneumothorax. Reviewing the bones, I can see bilateral degeneration of the short glenohumeral joints. Looking at the ribs to see any fractures, and I can see some posterior right, what looks like a healed rib fracture. Left, can't see anything on that side. And then looking below the diaphragm, there's no obvious abnormality on the diaphragm. And actually, I think there is a right-sided pleural effusion. So in summary, this patient has cardiomegaly, bilateral pleural effusions, upper lobe diversion, and this is in keeping with heart failure and likely explains the shortness of breath. Differentials for this appearance, at least the cardiomegaly, could be a pericardial effusion. And if there was a history of viral infection, then that could be an explanation. Would suggest that the patient has an echo, perhaps a BNP, and would discuss with the clinical team.
Okay, good. So I think, yes, you have summarized very well. So what you see here is enlarged the cardiac margins, or the heart shadow is quite enlarged. And yes, I can agree with you. There is slight blunting though, but yes, this is on the left side. Definitely, there is some sort of blunting. I'm not able to appreciate the rib fracture. I think you mentioned somewhere, but I'm not seeing any. Sorry. Yes.
Maybe the right posterior, just over the scapula. Maybe that's an odd.
So the sliding scapula sometimes mimic like a kind of a fracture or interface. All right. So apart from that, there is nothing that we could see. The trachea is in central. There is definitely mild splaying of the carina, and some degenerative changes in the humeral joints. So yes, the next step in this case has to be the 2D echo has to be done for this case, and then a referral to cardiology and as well as the ICU team. So again, especially in portable X-rays, so this magnification effect will always be there. So you have to exercise caution, and this is two different cases. So sorry, this is the same case where prior study just before the admission, and then there was no pericardial effusion though, and then post admission, and then over the course of time, patient developed pericardial effusion along with it. So always ask for the prior study if available, especially when you are in your clinical practice. And you have to do this comparison, especially when you want to differentiate between the two entities. So next case, you can take this case also. Yeah.
This is a upright chest radiograph of a 58-year-old presenting with abdominal distension. And the first thing I can see there's an abnormality is there appears to be air under the right hemidiaphragm, suspicious for pneumoperitoneum. Also appears to be air under the left hemidiaphragm, though this is less obviously appreciated. Looking at the remaining chest, the lungs are clear. There's no pneumothorax or pericardial or pleural effusion, and the cardiac contours. Well, I'm just looking at the behind the heart, and there is opacity projected behind the heart, suspicious for a retrocardiac mass or consolidation. There's no obvious hylonodal enlargement on that side. And then I'm going to look at the bone. And look at the bones, which some mild degenerative disease. So the findings are that this patient has features of pneumoperitoneum, discussed urgently with the surgical team. They need a CT abdomen and pelvis to further investigate this. Also, the findings suspicious of a retrocardiac mass, which probably could be appreciated on the CT abdomen and pelvis, but the urgent finding is the pneumoperitoneum. So yeah, that's.
Okay, so yes, you can actually appreciate the line outlining the right hemidiaphragm. So it's a clear air under diaphragm, and part of it you can actually appreciate along the left side also. Always look at the medial end of the clavicle. So this looks like a slightly tilted film, isn't it? So I think this may look like some sort of retrocardiac opacity. And apart from that, you couldn't see anything much in the lung parenchyma though. So the left angle is not very clearly opacified, or what would the left costophrenic angle compared to the right side, it is not clearly visible though. Apart from that, the bones look normal. The trachea is in center. The bronchus is the carina and bronchus appears normal. And yes, so the next step in this case is to refer this to refer the patient to the surgical team, and an urgent CT abdomen has to be done to look for the cause of pneumoperitoneum. So this is what that continuous diaphragm sign. Almost you can see outlining the entire diaphragm. So suggest of free air in the diaphragm, free air in the abdomen. So we did CT. CT confirms. This patient already had a previous history of left hemicolectomy, and this was secondary to a leak from the hemicolectomy site. Okay. We'll move to the next candidate. Next candidate can take this case.
Hello, sir.
Hello.
I'm the next candidate.
Yes, please.
So the given history is of 67-year-old male recently admitted to the ICU. I have been presented with a frontal radiograph chest of a 67-year-old patient who has been admitted in the ICU. I can see few lines and tubes and multiple ECGs suggesting patient is critical. The nasogastric tube is noted in place with its distal tip below the level of the diaphragm. However, I cannot appreciate its exact tip location. The endotracheal tube is noted within the airway. However, its distal tip is well below the level of the carina. So this is misplaced. The gross abnormality otherwise I can see is there is almost complete opacification of the left-sided hemithorax with ipsilateral pull of the cardiac and mediastinal shift. I cannot appreciate any gross mass lesion. There is no associated rib erosions. Yes, and on the contralateral side, the right lung is well aerated. In fact, I can appreciate that it is part of the upper lobe is crossing the midline. There is no effusion. The right hemidiaphragm is clearly noted while they're still hitting it of the left hemidiaphragm. To look at the bones, they appear normal with some degenerative changes in the right glenohumeral joint. So this to me this is a case of a misplaced endotracheal tube which is going into the right main bronchus, causing almost complete collapse of the left lung. This is an acute emergency and the ICU team needs to be immediately informed, and the endotracheal tube needs to be withdrawn, and the patient should be re-imaged after adjusting of the tube to look at the re-expansion of the left lung.
Okay, yes, very good. So let me just explain. Yes, the endotracheal tube is almost in the right main bronchus, main stem bronchus, and what happened was there is no air going into the left side, causing the left lung collapse and non-opacification of the left lung. So this needs to be urgently informed to the ICU team, and this needs to be pulled out and placed somewhere just around 1.5 to 2 centimeter above the carina for an optimal air circulation in the left lung. So remember, in effusion, there will be a contralateral effusion, and neoplasm usually causes the contralateral mediastinal shift. Atelectasis is always towards the ipsilateral side. So whenever you see a complete lung opacification, these three has to be your top differentials: atelectasis, pleural effusion, and neoplasm. So this was a case of a mal-positioned endotracheal tube with the complete left lung atelectasis. So I'll give you one more case to you. We'll have to conclude this session, this part of the session. So next, I'll give you a break of 5 minutes, and then we'll continue for the next session. In that session, I'll give you one more case.
Okay, sir.
So
Thank you.
accurate interpretation of findings on portable chest X-rays are very challenging, especially in critically ill patients. So these critical findings cannot be hidden on a can be hidden on a portable chest X-ray. So you need to be very actively. You have to look at all those hidden areas to get the diagnosis. Suboptimal technique usually impairs the detection of normal and pathological findings, especially in very complex cases or very sick patients. difficult to difficult to get the X-rays. And comparison with previous studies or previous X-rays has to be always there, especially when you're dealing with ICU X-rays, and it can definitely give you a diagnostic accuracy. And you have to have this consistent, systematic approach, and may decrease the number of missed diagnoses in the clinical practice as well as in the exams. We'll take a 5-minute break, and then yes, okay. I think the other candidate has taken only one case, so that candidate can take the
Sir, I'm
other
the
case.
candidate for, I've done the
Okay,
previous
okay.
one case. Yeah.
Okay.
Yeah. Thank you.
Okay,
Thank you so
yeah,
much.
thank you.
So I've been presented with multiple projections of the hand, frontal, oblique, and lateral, where I can see an oblique partially displaced fracture through the shaft of third metacarpal. On the lateral aspect, on the lateral view, I can appreciate that it is dorsally displaced associated with mild soft tissue swelling. Besides this, I'm looking at rest of the bones. So the rest of the metacarpals appear normal. The phalangeal joints and phalanges appear unremarkable. No intercarpal joint dislocation. Coming to the radius and ulna, I cannot appreciate any fracture. Ulnar styloid fractures in ulnar styloid is intact. There is a displaced fracture through the waist of scaphoid with posterior with dorsal displacement of the distal fragment. The lunate is also mildly rotated, giving a pine scan appearance on the frontal projection. However, its congruity with the radius is maintained on the lateral side. So this is this case is of mildly displaced oblique fracture of third metacarpal bone, along with complete displaced fracture of the scaphoid through the waist. This is the scaphoid fracture is an acute emergency. It should need to be immediately referred to the orthopedic team on call. And as this patient is at risk of developing avascular necrosis of the scaphoid because of the complete waist fracture. And the other fracture the metacarpal fracture can be conservatively managed.
Okay, very good. So let me just take over and I'll explain to the other candidates also. So yes, very good observation. You can actually look at first, as she described, there is a fracture line involving the third metacarpal bone, and on a lateral view, you can see there is some mild displacement and soft tissue edema is there. Then followed by we can actually appreciate the fracture line involving the waist of the scaphoid bone, and there is some mild impingement along the course of the distal radius. On lateral view, we can actually appreciate the dorsal displacement of the uh, uh, other metacarpal, followed by the lunate is in place. You can actually appreciate the lunate is in place. So this is a classic case of a perilunate dislocation. So what happens in perilunate dislocation? Let me just show you a picture. So the capitate will displace. The lunate will be incongruous with the radius bone. So remember this diagram. So metacarpal, what happened? Metacarpal dislocation. The lunate will also the lunate will dislocate. The capitate will be in place. In a lunate dislocation, only the lunate will dislocate and the capitate will be in place. So this is from the article, from the radiographics. So you can actually go through this article. It's a very nice article. So the teaching point in this case is this will lead to median nerve injury, and avascular necrosis is common, especially in cases of waist of scaphoid fracture. So you need to do this, you need to urgently refer this case to orthopedic surgeons, and then you recommend CT for, if it is planned for, definitely for pre-operative planning, need a CT, and also they do this K-wire fixation of the fracture site. Whenever you are given a wrist radiograph, remember the arcs of Gulila. So there are 3 arcs. See, the arc 1 or first will this yellow line indicates the line which describes the distal radial joint congruity or its alignment, whether it is there should not be any negative or positive ulnar variance in this alignment. Then arc 1 has, as this line goes along the scaphoid and lunate and also the triquetrum. So this line has to be very smooth and there should not be any disruption. That is arc 1. Arc 2 is the distal concave surface of the scaphoid lunate and the triquetrum, the green one. The purple one is the arc 3, where it follows the main curvature of the hamate and capitate bone. And these are the other arcs I call. The other yellow line indicates a sawtooth appearance, or zigzag pattern has to be maintained with the distal metacarpal bone. So there should not be any discontinuity in any of these lines. Again, the brown line also, you need to look at the alignment pattern, so that there should not be any associated fractures in the metacarpals. So you should follow a checklist, especially when you are in the exam. So look at the alignment and the arcs, the joint spaces and the gaps, and the carpal bones in a systematic sweep. Look at the scaphoid, waist, and poles, the cortex, trabeculae, and very important, look for fracture and avian. The lunate bone, triquetrum, pisiform, you have to go through this systematic sweep. Distal radius and ulna, styloids. Styloid fractures are also can be missed, especially the undisplaced ones. Then finally look at the soft tissues, look for swelling, any foreign bodies, or if there is any KOS being fixed, and look at its position and see if there is any fractures involving the or if there is any loosening of wire or screws in and its complications. Okay, we'll move to the next candidate, and the next candidate can take this case.
Okay, I am provided with a frontal radiograph of a pelvis of a slightly mature patient. I'll take a time to examine the radiograph before conveying my findings. Okay, I did not detect any gross abnormality, so I follow my systematic review. First of all, I can see non-specific bowel gas line appears grossly normal. I'm following the foramina and the sacrum as well. Both sacroiliac joints appear normal. I'm following the iliac bones. They appear normal, and the symphysis pubis, as well as the superior and inferior pubic rami. I'm following the iliopectineal and the ischiopectineal lines. Okay, and then I'm following the femurs. The rasa trochanter and the greater trochanter are preserved, but I'm suspecting some discontinuity. I don't know if it is projectional. I can see there is a line as well. There is a catheter. There is a catheter, likely a bladder catheter. Okay. This is a frontal radiograph. So the femoral heads appear normal. This is a suprapubic catheter. Okay. I'm sorry. Okay. So there is a there is a catheter seen, but I do not see any air along the bladder wall.
Okay.
So yes, I'm following I'm suspicious about the left hip joint and the pubic rami. There is discontinuity along the left iliopectineal line. So yes, here. So yes, there is a subtle superior pubic ramus fracture. I'm also suspecting there is discontinuity. I'm not sure if it is projection or not. At the right femoral head, there is some discontinuity, and what feels to be like interrupted Shenton line. Yes, there is some subtle discontinuity along the Shenton line. So I'm suspecting a fracture along the left femoral head as well, subcapital. So together with the superior pubic ramus and the this is pelvic fracture with the suprapubic catheter insertion. I immediately convey the findings because this can be associated with injury to the bladder. So I'll advise for CT CT to exclude any bladder injury and maybe ascending cystogram. And also, if there is a fracture at the left femoral head, this can lead to AVN. So I'll immediately convey the findings with orthopedic referral and also advise for lateral view of the femur to detect if there is any other fractures, other orthogonal view with orthopedic referral to manage the fracture to avoid AVN of the femur. And yes, with the left superior pubic ramus fracture, other than that, I do not see any other fracture lines.
Okay. So you said it's a suprapubic catheter, but see this, it's just kind of it's folding on itself, right? So this is somewhere outside on the skin surface or at the, these are not a suprapubic catheter. So be very careful when you're giving this in the exam and look at its continuity. So you can actually see it is just going somewhere here and it is just folding up here. So it's just not related to the
Okay.
what do you call it, the suprapubic catheter part. Okay, so yes, the description was correct. So it took a while, it took some time for you to find out, but you can actually see there is a discontinuity in the iliopectinal line, especially on the left side. So let me just show the CT scan. So you can actually, that's the CT scan of a patient. On the right side also, you can actually appreciate very nicely, not very nicely, but it's a little bit subtle elevation.
Okay.
So let me just explain the lines. It's very important. So please take this. There's a nice article on all this description of the lines. So the three lines are very important: the iliopectinal line, the ilioischial line, and the Shenton's line, which you have talked about the Shenton's line, I think. So
Yeah.
Shenton's line is drawn along the inferior pubic ramus, inframedial border of neck of femur. So where inferior pubic ramus, it has to cross along the neck of femur. This line has to be maintained, and it has to there should not be any disruption in this line. The next line is the iliopectinal line. So as the name suggests, the smooth line joining from along the anterior iliac wing up to the superior border of the pubic bone. So usually anterior column fractures is mostly disrupted. Anterior column fractures disrupt this iliopectinal line. And of course, in Paget's disease and hyperphosphatemia, there can be thickening of this line. The third line is the ilioischial line, where it's a lateral border of the obturator foramen to the medial border of iliac bone. Especially this line gets disrupted in cases of posterior columnar fractures. Okay.
Okay.
So a small checklist you should have, or you should prepare your own checklist, especially when you approach the hip radiographs. So look at the lines and symmetry, look at femoral head and neck, especially the contour, trabecula, fovea capitis. Look for subtle cortical breaks, sclerosis, or if there is any collapse or subluxation. Trochanter and proximal femurs, acetabulum and pelvic bones, and sacroiliac joints and lumbar spine. The visualist lumbar spine, you should look for SI joint space, especially in cases of inflammatory or Crohn's disease. There will be inflamed SI joint spaces. Then finally, look at the soft tissue. Look for effusion, fat planes, if there is any calcifications or heterotropic ossifications. You mentioned something with the neck region here, so I think that's just because of the projection. But yes, you are right on, raise a suspicion. But we did a CT. CT was not showing any fractures or anything in the neck region.
Okay.
Okay. So this is the next case for you.
Okay. So I'm provided with a frontal and lateral radiograph of an elbow of a slightly mature patient. On the lateral radiograph, I can see there is elevated anterior fat pad, suggesting the presence of underlying fracture. I'll follow the line, the anterior humeral line and the radiocapitular line. The radiocapitular line intersects the capitulum and the anterior humeral line intersect the capitula. However, I'm suspecting on the lateral view that there is discontinuity and cortical disruption along the radial head. I'll just examine also the AP view. In my routine practice, I may zoom a little bit as well, but on the AP view, I'm just following, there is subtle discontinuity along the radial head. Other than that, I'm examining for any other fractures. The ulna appears grossly unremarkable. I'm suspecting some discontinuity along the medial femoral condyle. There is some discontinuity along the cortex. However, I do not see any supracondylar fractures or condylar fractures, lateral condylar fractures. There is no dislocation of the elbow joint. Okay, so I convey the finding, I have the AP in the lateral, I convey the finding that there is an elbow radial head fracture. There is minimal display, I mean, on the lateral view, there is some displacement of the fracture fragment. Okay, but no joint dislocation with joint effusion. So I'll convey the findings with orthopedic referral for adequate management.
Okay. Yes, very good. So actually, someone had asked in the chat box about the previous case diagnosis. I'll just so the previous case diagnosis, bilateral superior pubic rami fracture. That's all. Yes, in this case, very rightly pointed out, you can actually see the partial or minimally displaced fracture of radial head, and there is effacement or a positive anterior fat pad sign. So you did mention this, the anterior humeral line and the radiocapitular line. So very important, especially in cases of pediatrics, you should definitely measure this line. So what is this anterior humeral line? So it's a line drawn along the anterior surface of the humerus, and it should intersect the mid 1/3 of capitulum. And the radiocapital line is a line drawn along the neck of radius, and it should again intersect the capitulum. These are the two other diagrams where you can actually see that's the normal anterior fat pad and posterior fat pad. In cases of joint effusion, you do see there is increase or effacement of the fat pad with fluid, and you can also see the positive sale sign. So, especially for an elbow, look at the bones and joints, follow the cortex of humerus and radius, the ulna, check ulnohumeral, radiocapitular, all the lines, and rule out Monteggia and Galeazzi fracture. Monteggia is proximal ulna, and distal radius is the Galeazzi. And look at the alignment lines, fat pads and effusion, dislocation, and if there is any instability, you have to mention. Soft tissues, and you need to compare if there is any intraarticular fragments, and compare with the opposite side if you have it, or always look at the orthogonal plane in especially in cases of pediatric abnormalities. So final diagnosis in this case, minimally displaced fracture of head of radius with positive fat pad, anterior fat pad sign.
Okay.
Okay, we'll move to the next candidate.
Hello, good evening, sir.
Hi, good evening. So this is a skull radiograph. Patient has a history of headache and pain and headache. So diffuse pain and headache.
This is a frontal radiograph of the skull as well as the occipital mental view. First of all, I would like to correlate whether there is any history of trauma.
No history of trauma.
Okay. So the bilateral frontal sinuses, these are well opacified, and the bilateral maxillary sinuses, these are also well irritated. Bilateral frontal sinuses are also well irritated, and the nasal septum is central. Apart from that, the bilateral mastoid air cells, these are also well irritated. I'm looking for any cause of the patient's symptoms, the cause of the headache, and I'm looking for any osseous lesion. So there is no aggressive osseous lesion noted, and there is no obvious fracture.
Mhm. I'll give you another clinical history clue.
Uh,
Patient is having a severe headache,
yeah,
predominantly on the left side.
okay. So this patient has predominant headache on the left side. So I'm looking at the bilateral sphenoid wings and I'm comparing these. And these look fine. And further, I cannot appreciate any soft tissue abnormality. And I would like to see another orthogonal view if available.
No, only these two views are there.
Okay, I can appreciate that the patient has multiple tooth filling, and
Look at the bones carefully. Do you have a search pattern, especially when you have for a skull radiograph?
yeah, I start from top to the bottom. So I can appreciate that the zygomatic bone, it appears unremarkable. Bilateral zygomatic bones are unremarkable, and there is a subtle lucency which is noted in the frontal process of the zygomatic bone on the left side.
Okay. Okay.
So I would, yes.
So what will you do next? What is your,
First
do
of
you
all, I
have
will,
any
yeah.
differential?
Yeah, first of all, I will compare it with prior imaging, and this lucency, it needs further evaluation with cross-sectional imaging, further CT scan.
Okay. Let me just take over. So first this, are you able to appreciate this expansion of the left zygomatic arch? Look at this expansion. Do you
Yes.
think it's normal on the right side? That is this one. Of course, it's not very clearly seen on the right side though, but here you can appreciate to some extent. But on the left side, yes, this is again, it's not a correct view on this side, but the Waters view is very nicely, you can actually appreciate a nice expanded left zygomatic arch with some lucency also within the expanded arch of the zygoma. This was the MR of the same case. So you can see expanded left zygomatic arch on the infratemporal fossa. You can see fluid levels. So where do you see fluid levels?
Yeah.
What do you
My
think?
differences in yeah. My differences include aneurysmal bone cyst, and yeah, this is my top differential, and telangiectatic osteosarcoma is less likely as there is no large soft tissue component.
Okay.
And
So
the
this was
other
a case of
differential is
a Yeah. Yes. Yes.
Yeah.
Okay. So yes, so this was a case of a aneurysmal bone cyst. So the patient underwent left a subtemporal craniotomy with resection of the mass. So a very nice, again, one more good article, especially to look at the skull and facial bones. They have given a nice checklist. So please go through this article from the e-posters from European Congress of Radiology. So that's the checklist actually, where you have to look at the calvarium and sutures, anterior skull base and frontal sinuses, look at the orbits and the zygoma, trace very carefully. The zygomatic arch has to be traced very nicely. So, and this line has to intersect the maxillary inferior aspect of the maxillary sinus. Again, the orbital line. See, the orbital line has to be very smooth, and there should not be any breach or discontinuity. And mid-face, look at the maxilla and nasal bones, assess for the Lefort pattern of injury, and look at the temporal bones and skull bones, skull base foraminas, and also look for the associated intracranial and soft tissue filling defects if there is anything. Okay, next case for you. This
It is
one,
a friend.
history of twisted injury. He had history of fall and followed by twisting injury.
These are frontal and lateral projection radiographs of the left knee of a patient who has history of fall and twisting injury. So first of all, I will have a look at the radiograph and then I will describe my findings. Um, I can appreciate that there is soft tissue haze in the left suprapatellar region, suggestive of suprapatellar joint effusion. And there is also suspicion of some fluid level also, which is concerning for the lipohemarthrosis. However, the best view to see would be the horizontal beam view. And apart from that, there is no bone fragment noted lateral to the tibia to suggest second fracture. Um, there is impression of a small bone fragment in the interspinous region. In my routine practice, I would zoom it to see whether this is actual finding or not. So this is not the actual finding. There is no bone fragment here in the interspinous region.
Okay.
And I can appreciate that there is asymmetry of the condyle. Femoral condyle, intercondylar region is asymmetric, and the patella is normal in position. There is no joint dislocation. So based on this finding of the asymmetric condyle of the left femur, as well as suprapatellar joint effusion and impression of lipohemarthrosis, I would further advise MRI knee to rule out further injuries, and I would like to see the lateral beam radiograph, horizontal beam radiograph if available.
Horizontal beam. Okay. I've done an MR for this case also. So of course, MRI in short cases is not. I'm just correlating all my cases with an MR. So I'm just giving an MR so that in plain radiograph you will not get all this correlation, especially in the exams. So do you see anything in this case?
I can clearly appreciate bone contagion, which is noted in the tibia and proximal tibia as well as in the distal femoral condyle as well. Yeah, and further, there is subtle high signal in the tendon in the intercondylar notch, in the ligament, in the posterior cruciate ligament in the intercondylar notch. In my routine practice, I would scroll all the way to see it.
Okay, yeah, fair enough. So this was a case of an ACL tear. So yes, like you said, probably we need to scroll and see, but definitely somewhere near that mid substance, there is some partial tear mid substance on the proximal aspect. From the femoral aspect, there is a partial tear. What I want to show is this aspect. So you have to in a plain radiograph, you can actually see this deep sulcal sign or the deep notch sign, where a line drawn over the lateral femoral condyle and a small perpendicular line at the notch. So that's the deepest point of the depression. So anything more than 1.5 is you should have an high suspicion of an ACL tear. So in our case, it was almost like 1.7 mm in this case. So yes, there is definitely suprapatellar joint effusion. And the other aspect, I think something you mentioned in the intercondylar notch, it is nothing is there in the intercondylar notch per se. Otherwise, yes, yes.
This condylar, this intercondylar area appeared asymmetric to me. So I think it is
Yes, we
projectional.
can
Yeah.
actually, yes. Oh, the intercondylar. Okay, yes, yes, definitely. That's just the projection, and no other fractures that we could appreciate on the plain radiograph. So our final diagnosis in this case is the deep sulcal knot sign, uh, uh, which is seen in anterior cruciate ligament injury. All right, so we'll go to the next candidate. Probably I'll just, this is the knee X-ray checklist. So look at the femoral condyles and tibia and fibula you have to look at, and especially the fractures and associated ligamentous injury, joint space and its alignment, the patella. If there is any associated variance, you should mention. Patella alta, or if there is a tilt or subluxation, all has to be mentioned in the report. Soft tissue and effusions. If it is a tumor or a bone lesion, screen for age. The location, epiphysis, metaphysis, where is the origin? What is it in the medulla or in the cortex? Look at the matrix. Is it lytic, sclerotic, chondroid, osteoid? All this has to be mentioned if you're dealing with a tumor in any joints. All right, so next candidate can take up this case.
Hello, sir.
Hi.
Shall I start, sir?
So this patient came with history of low back pain.
Okay, sir. I've been provided with frontal and lateral radiograph of the lumbar spine. I'll take few moments to go through the radiograph. Here I can see that the left pedicle of the L1 vertebra is not well visualized, and on the anteroposterior radiograph, and on lateral radiograph, I'll try to correlate. Okay, on lateral radiograph, I can see that there is some lucency in the region of the posterior element of the L1 vertebra. However, it could be projectional as well. I will go through rest of the pedicles, and they are appearing normal. Then degenerative changes are seen in the spine in the form of lucency and end plate sclerosis. There are atheromatous changes of the aorta seen. However, I'm not seeing any aneurysm. So bilateral psoas shadows are well maintained. So in my routine practice, I'll correlate this with the patient's history and whether the patient has any known malignancy, and will ask for the MRI for further evaluation of this patient.
Okay. That's the CT.
On the provided image, representative image of the axial CT scan, I can see that there is well-defined lytic lesion involving the posterior body of the lumbar vertebra, which is extending into the posterior element on the left side. The posterior cortex appears to be distracted with the soft tissue. So, considering the bilateral small kidneys and presence of calcifications within, in my routine practice, I'll correlate this with the age of the patient. However, this appears to be elderly patient, so my differentials would be first metastasis, then myeloma, and lymphoma as well. So I'll inform these findings to the referring physician and will ask for the CT guided biopsy of this mass to for histopathology and further treatment and management of the patient.
Okay. So, yeah, you mentioned myeloma and metastasis and lymphoma. Probably myeloma, do you think it'll involve only a single bone? So be cautious in the exam. So don't put myeloma as your first differential, especially in these cases. And probably to some extent, I can agree with lymphoma and metastasis.
Okay, sir.
So this was a case of, sorry, it turned out to be a Brown's tumor. So again, you should keep some other benign etiology also in your differentials. How about aneurysmal bone cyst can also be one of the possible differentials. So
Yes, sir.
myeloma, I'm not very convinced with this as your first differential. So be very cautious in the exam. All right.
Yes, sir.
So lumbar spine, again, some checklist. So you can create your own checklist. So or you can follow this sort of checklist. So look at the alignment and curvature, look at the vertebral bodies, assess the height, look for any wedge compression fractures, cortical integrity. You need to check, is there any trabecular pattern or sclerosis, lytic lesions at each level, whether disc spaces are maintained, and is there in-plate sclerosis. All this has to be checked up. And posterior elements, if there is any fractures involving pedicles, lamina, and facets, spinous process, pars defects, spondyloarthropathies, and listhesis. And pelvis, sacrum, and soft tissues should also be assessed while looking at the lumbar spine radiograph. All right, so next case, you can take this case.
Yes, sir. I've been provided with frontal and lateral radiograph of the knee joint. I'll take few moments to go through the radiograph. I'm looking at the cortices on AP radiograph. I'm not seeing any obvious fracture. On the lateral radiograph also, so in the patella, I'm seeing some lucencies on lateral radiograph. However, it could be projectional. There is increase in the soft tissue swelling. So as this is an elderly patient with a severe pain after twisting the knee, I'll look for any.
Look at the medial aspect. Do you see anything?
There is some lucency overlaying the medial condyle of the femur, where not sure whether it's just projectional. In my routine practice, I'll ask for MRI as I'm not seeing any definite abnormality on the X-ray.
Okay. The MRI.
Okay. I've been
So
provided with
these two. Yes, these two are the PD fat cell images, and this is the T1.
Yes, sir. These representative images of the MRI knee, I can see that as seen on the X-ray, there is increased fluid signal on PD fat set images in the lateral femoral condyle. There is also increased signal in the anterior cruciate ligament as well. On T1 weighted images, I can see that the hypointensities, linear hypointensities through the lateral femoral condyle. So I'm suspecting fracture. The fracture involving the articular surface of the lateral femoral condyle. So I'll inform this finding to the referring orthopedician for further management. And I'll also scroll through all the images to look for any other ligamentous injury. And whether it's pathological fracture secondary to the any bone lesion as the patient is elderly.
Okay. So, like I said, you need to have a strong suspicion, and again, you have to go through those checklists, look at the condyles, both the medial and lateral condyle, the tibial plateau very carefully, the intercondylar notch, look at the patella, and see if there is any abnormal lucencies or any lytic lesions in the patellar surfaces. So, very subtle though, but you can actually appreciate this very nice area of density involving the medial aspect of the medial condyle of uh, uh, femur. So on MRI, you can actually appreciate that there is some sort of a fracture definitely on T1 weighted imaging, and severe edema involving the medial aspect of the femoral condyle. So this was a case of a subchondral insufficiency fracture involving the medial femoral condyle. So very important to mention, on a plain radiograph, you need to talk about suspicious density involving the medial condyle of femur, and in a trauma history after a twisting knee joint. Even though the edema could not be appreciated that well on a radiograph, probably you can give a differential. So osteochondral fracture versus subchondral insufficiency fracture. So important differential is the osteochondral fracture. Fracture line will extending to the joint surface. So depression of subchondral plate, and there will be an articular surface disruption. So in our case, none of this are there. Only there is a fluid-filled cleft. We can actually nicely appreciate on the PDFS imaging as well as in the T1 weighted imaging. So we can actually see some small thin fluid cleft actually, and a very classic case of subchondral insufficiency fracture. So what does it indicate? It indicates a secondary osteonecrosis, and also there can be an associated meniscal tear, and you need to carefully rule out in these cases. All right, so we'll move to the next candidate.
Hello, good evening.
Hello, hi, good evening. Yes. So this patient has, I'll just tell you the history. He's got pain and swelling in the phalanges, especially the third and fourth.
Okay, so this is an frontal hand radiograph. So I can see at the second and the third finger, I can see at the middle phalanx there is sclerosis with lucency seen within both middle phalanx bone. I cannot appreciate any cortical erosions. Looking into the joint spaces, they look preserved in both fingers around this bone. I can see there is a soft tissue swelling surrounding these bones. Looking at the rest, looking at the terminal phalanx, they are unremarkable. The rest of the joint spaces are unremarkable too. So the appearance of sclerosis with lucency in both middle phalanx with soft tissue swelling. I'm thinking of sarcoid, giving the lucency with sclerosis. Another differential could be also osteomyelitis, but I cannot appreciate any cortical erosions. So I would notify the referrer with this finding. I would compare this to any other film if available, and also if this patient have a chest radiograph, I will also have a look at it. And yes.
Okay. Okay, good. So yes, this was a case of a sarcoidosis. So what you see here is typical lash-like pattern, predominantly involving the mid phalanx, particularly the third and fourth. And if you see here also the thumb or the first terminal phalanx also kind of irregular. So, and of course the central trabeculae is also not very clear, or it is kind of irregular marrow. So this is how that lash-like pattern looks like. So next step is to look for the history, previous radiographs, and also to do CT chest screening and serum and ACE serum ACE levels, angiotensin converting enzyme levels has to be done for these cases. And of course, you have to refer this case to the MSK specialist also, and rheumatologist for further evaluation. Okay, next case.
Okay, so I'm presented with a foot radiograph of an 18 years old male with history of seizures and swelling and bruising from a fall 2 months prior.
So ROS is the review of system.
Sorry?
Review of system. Examination of physical examination.
Okay, yeah. So I can see at the there. I can see there is actually. I can see there is a fracture seen at the base of the second metatarsal bone. And I can appreciate there is some widening in the space between the first and the second metatarsal as well. Looking at the rest of the metatarsal, I cannot appreciate any fractures. Looking at the rest of the bones, I cannot appreciate anything else. So, giving also this history, I'm suspecting that with the fracture at the base of the second metatarsal, this is a less frank injury. I would notify the referrer urgently, and this patient would need a further CT for further characterization and see if there's any bony fragment. And also he may need an MRI to look at the less frank ligaments. And further orthopedic review as well.
Do you still feel it is a Lisfranc injury? How about the bone mineral density in these cuneiform, the medial cuneiform, the navicular bones? Do you think it is normal?
No, for the age of 18 years old, no, it's not the normal. It looks less
Yes,
dense, yeah, than usual. Yes.
so do you
Yeah.
still want to keep this Franek as your one of the differential, or anything else, any other differential you want to add?
Given the history of fall and also this low density within the bone, it could be disuse osteopenia. Another thing also, it could be Charcot Jones, but I cannot see any like distension of the bones. I cannot see any debris. I cannot see any bony particles within the joints, but still my main differentials are it's disuse osteopenia, or it could be a Charcot joint, giving the history of foot swelling and worms foot.
Okay. So very important to take the clinical history and you have to correlate, isn't it? So this patient also has foot swelling, warmth, bruising after a fall 2 months ago. So, if you look at it, so you are very correct. You did pick up the fracture lines very well, and grossly the bone mineral density is lost, especially involving the midfoot. The the cuneiform medial and lateral cuneiforms and cuboids and the navicular bones all has got osteopenic changes with some fractures. You can actually appreciate some small fracture also in the medial cuneiforms. These ones, some cortical irregularities are out there. So MR was done for this case. You can actually appreciate irregular soft tissue thickening involving the joint spaces, which you did mention. I think you talked about widening of joint spaces on the plain radiograph. So
Yes.
what I want you to see is the on post T1 fat suppressed image, you can actually appreciate some pinpoint or punctate hemorrhagic foci. So these are all hemorrhages, especially the intraosseous hemorrhage. And if you look at the history very carefully, this patient also has got gingivitis. So put all and again nose bleeds. So these are all case of a vitamin C deficiency. This patient has a scurvy. So of course, I'm not asking you to give me a diagnosis of scurvy based on the radiograph, which is a wild imagination. So the reasonable is complex pain regional syndrome, osteomyelitis, and your Charcot joints or complex regional pain syndrome kind of picture. So these two will definitely has to be on your differential diagnosis. All right. So we'll move to the next candidate. So the checklist for foot and ankle X-rays. Look at the forefoot, midfoot, and hindfoot. So you have to look at the arches alignment, joint space, soft tissue swelling. Look for any air foci, foreign bodies. If you are confronted with a tumor, look at the location, matrix, periosteal reaction, and soft tissue mass. All right. So next candidate.
Yes, hello.
Hello. So I'll give you a brief history on this case. He's a 30-year-old male who presented to emergency department with history of breathing difficulty.
Okay. I'm presented with a frontal chest radiograph of a 30-year-old male who has presented with breathing difficulty. I can see that there are prominent bilateral hilar shadows. In the aortopulmonary window, there is a opacity that is tapering towards the lower aspect, giving the appearance of a enlarged pulmonary artery. I can also see that there are prominent bilateral bronchovascular markings along with pruning peripherally. I don't see any pleural effusion. I don't see any cardiomegaly. I can see that there is some hyperexpansion in the lung volumes. I am looking at the bones to assess for any bony abnormality. I cannot appreciate any fracture, any pneumothorax, any pneumomediastinum. In my routine practice, I would also just window it more to see the vertebral bodies better. To summarize, this is a case of bilateral pulmonary artery enlargement, possibly pulmonary arterial hypertension. I would raise the possibility and advise a referral for CT pulmonary angiogram or as well as a pulmonology referral. If this patient is young, this can be in a primary pulmonary hypertension without any cause. However, associated causes need to be ruled out. Yes, thank you.
Okay, very good. So yes, you can actually see bilateral hilar enlargement, and the important point here is look at the smooth margins of hilar. So probably to some extent on the left side looks kind of a smooth. On the right side maybe slightly irregular because of the rotated film. That is how pulmonary hypertension will present as smooth hilar margins, and with some subtle enlarged right side of the heart, you can actually see the right cardiac margin slightly enlarged. So a typical pulmonary arterial hypertension. In cases of hilar lymph nodes, so it will be irregular, kind of, even though it may not appear this smooth. So that's one of the important differential for enlarged hilar lymphadenopathy. Irregular kind of picture, and you sometimes in cases of TB, hilar lymph nodes will also TB and sarcoid. They can throw some calcifications. So if you see calcifications in with hilar enlargement, you should think of a hilar lymphadenopathy. So I think most of you know checklist for a plain radiograph of chest. Sorry. Look at the lungs. So either an approach from lung, mediastinum, heart, followed by pleura, bones, or you can have a vice versa from bones, pleura, and then you can check the mediastinum, heart, and finally the lung pattern. But you have to create your checklist and follow it in the exam. Okay, next. So 3 cases, probably you can describe the 3 cases.
Okay, so the first one is a 56-year-old patient planned for CABG, and this is for routine workup. I can see that there is elevation of the right hemidiaphragm, significantly above the level of the left. I cannot see any associated apical mass lesion. I cannot see any hilar lymphadenopathy. I don't see any lung mass or nodule. If this is a patient who is asymptomatic, the first thing I would think of is diaphragmatic eventration. If there is any prior films, I would compare it to them just to see if this is a new finding, in which case I would be concerned for any palsy of the phrenic nerve. Otherwise, this can be just an asymptomatic finding that does not require much in terms of management. The second case is a 44-year-old with thyroid carcinoma, post-total thyroidectomy and level 4 neck dissection. I can see that there are multiple lines and tubes. There is a tracheostomy tube in appropriate position. The NG tube tip is not visualized, however, it is seen projecting below the diaphragm. Thank you. I am looking, again, I can see that the right hemidiaphragm is significantly elevated in comparison to the left. With a history of thyroid carcinoma and post-resection, there is a high probability that this patient has an injury to the phrenic nerve. I can also see that there is the left central line, a PIC line in appropriate position. So for this patient, I will compare it to any preoperative chest X-rays if available, because that would make my suspicion of phrenic nerve palsy more like that would support the diagnosis of phrenic nerve palsy or phrenic nerve injury. This patient requires referral to physiotherapy. And also a neck MRI can be done to assess the residual soft tissues. Otherwise, the lung parenchyma, it appears to have small nodules. These may represent like calcified granulomas or healed metastasis. They appear to be high density or healed infection. There is no pleural effusion. The cardiac border is normal. I can see that there is a kind of linear opacity projecting at the inferior and medial aspect of the right hemidiaphragm. This can be projectional, it can be artifactual if there is something on the shirt of the patient because it is not conforming to the lung lobe anatomy. Other than that, the soft tissues are they are symmetrical. Breast tissues are symmetrical. And I can see some postoperative changes in the visualized cervical neck.
Okay. How about this case?
This is a 6-year-old with dry cough, frontal radiograph of a skeletally immature patient. I can see that there is a hazy opacity that is projected at the lower lung zone. It is not silhouetting the hemidiaphragm and it is not silhouetting the right cardiac border. So it can be in the middle lobe lateral segment, which is why it is not silhouetting the heart, or it can be round pneumonia. Just because of the round configuration, it is not silhouetting the cardiac border. In my routine practice, I will compare with the previous radiographs, and this patient requires a follow-up after the symptoms have resolved or after the treatment, just to make sure that there is no underlying mass, because round pneumonia can basically hide or mimic masses. Other than that, I think there's minimal. I don't see any blunting of the costophrenic, any significant blunting of costophrenic angles. I don't see highlighted lymphadenopathy. I'm looking at the ribs. The ribs appear unremarkable. I don't see any pleural pneumothorax, or pneumomediastinum. So this patient requires treatment with antibiotics and then a follow-up after 4 to 6 weeks just to assess for resolution.
Okay. So actually, I have got a lateral radiograph of the first two cases. Just have a look, maybe kind of helpful if for your diagnosis.
So the first case, the lateral radiograph, there's a very smooth contour. There is no focal area of bulge. So it doesn't look like Bogdalic or Morgagni hernia. It looks more of like a complete diaphragm elevation, which can be a normal variant.
Okay.
And for the second case, there's like flattening of the diaphragm that's not bulging as much. So it would support the diagnosis of phrenic nerve palsy. Not
Okay.
sure.
Yes, very good. So excellent description. This was a case of a diaphragmatic eventration. So what you see is the sharp margins and the deep posterior costophrenic angle. So due to the central weak tendon. So you can actually appreciate on the lateral radiograph. So a deep costophrenic angle. And so if it is acquired, so frequently it will be on the left side, congenital most common on the right side. So if it's, you have to think of a Beckwith-Weidman syndrome in young or in pediatric cases and associated trisomy 13 and 18. And sometimes if you see bilateral, then previous history of toxoplasma infection can cause bilateral diaphragmatic eventration. Yes, the next case is a very classic case that if you see the lateral radiograph, that is how you differentiate between eventration and diaphragmatic palsy. Diaphragmatic palsy will have kind of an irregular appearance compared to a smooth appearance in the eventration kind of picture. The third one is a nice case. It is a case of a round pneumonia. So that's how it will project in the right lower lung zone kind of opacity. So with intact right heart border and the right hemidiaphragm, so no erosion. So differential, you have rightly mentioned, it has to be either a Bogdalic or a sequestration. Can also be one of the differentials. So you have to refer this case for an antibiotics review after 4 to 6 weeks post antibiotic course, and then repeat chest X-ray. For the central, you need to refer this for a physiotherapy for to recover the diaphragmatic nerve palsy. So she mentioned something which is on this side, but this opacity could be a part of plate atelectasis, or usually plate atelectasis can happen, but horizontal is it's kind of rare. For this one, eventration, you don't have to do anything. You just have to follow up. And if it is symptomatic, then diaphragmatic repair can be done. But if there is asymptomatic, these cases can be just simply followed up. All right. I think I gave you two cases, or
Yeah, thank you so
one.
much.
Yes. So, next
Hello, sir.
candidate. Hello.
Yes, sir. Yes, sir. Okay, so this is X-ray chest frontal projection. I can see the central venous line on the right side, and it's appropriately placed, and rest the okay. So these both X-rays are of the different patients, right?
Yes, both X-rays are
Yeah.
of different
Okay.
patients. So I'll give you
Yeah.
history on this patient and this patient also. So this patient presented
Okay.
with history of jaundice and dark colored urine, and this patient presented with cholestatic jaundice.
Okay. All right. So now I am looking at both lung fields. No evidence of any parenchymal abnormality is seen. No evidence of pleural effusion. And right, there is a small lobulated density is seen in the right hilar region. It could be a lymph node. Other than that, the paratracheal strip is normal, and there is like unfolding of arch of aorta. And no pneumothorax is seen. Now I'm looking at the bones. The bones appear normal. I can see that there is a high density area is seen in the right subdiaphragmatic location. In my normal practice, I would zoom. I would make the contrast better to see it, and so it's yes. So
So which
there is
one do you want
a
me to zoom? The first radiograph, or?
yes, first one. I'm describing the first one. I can see that there is a high density area in the right subdiaphragmatic lesion. So it's likely it could be a liver lesion, or any hydatid cyst, um, or any abnormality in the gallbladder, as patient is presenting with jaundice, right?
Yes.
So yeah, it could be the gallbladder. So yeah. So I would convey my findings to the referring doctor, and this patient would need further evaluation with a CT scan, and yeah, to
Okay.
characterize this area better.
So this is a case of a pneumobilia, and this was a case of a portal venous gas. So let me just zoom it up for you. Can you see here? There is a central branching pattern. Can you appreciate?
Okay. Yeah. Yes.
So these are post ERCP. Sometimes patient can present like this, or other possible differentials includes gallstone ileus or cholangitis. So remember this case I purposefully put so that you will have your checklist, and I gave you history also. Patient is having a jaundice, so you should focus something here, right? So these are all definitely not normal. Branching lucencies going centrally, which is a typical of a pneumobilia. Then the next case, you can actually see lucencies extending into the periphery. Can you see here? There also, almost along the periphery, you can see some sort of a branching lucency. So typical of a portal venous gas. So if you look at, if you see this kind of pattern, think of ischemic colitis and pneumatosis intestinalis. And if you are confronted with this similar kind of X-ray in pediatric cases, think of a necrotizing enterocolitis. Otherwise, the lungs appears actually normal. The mediastinum in both cases appears normal. So there is not much of a finding. So this is to catch you off the grid and see whether you are looking at it very carefully. Okay, we'll show you next on this case. Yes.
Okay, so these are X-ray abdomen of a pediatric age group patient. There are multiple dilated small bowel loops are seen in the abdomen, and I cannot see the normal air within the rectum. In my normal practice, I would zoom the images to look for the pneumoperitoneum air in the within the liver. Other than that, so yeah, in these images, I cannot see the free air. I'm trying to look at the mottled lucencies, which I am not able to appreciate. So I'm thinking that this is a case of the distal intestinal obstruction. My yes. Okay. On the yeah, there is no free air, so it's a case of distal intestinal obstruction. My differentials would include meconium ileus or the Hirschsprung disease. So I would convey my findings to the referring doctor, and this patient needs a surgical referral and evaluation with the barium studies.
So you are convinced there is some bowel pathology in this case.
Okay.
No,
I'm looking
this
at the
case is just to assess the probably I'll give you a
okay.
big clue in this. It is little difficult, I can understand. So this patient we
Bones, I should
placed
have looked at bones. Yeah.
no, not bones. We did the
Catheter.
umbilical artery catheterization.
Okay.
So
Okay.
this
Yeah.
is a check X-ray to see whether the catheters are in situ.
Okay. All right. Yeah. The umbilical arterial catheter is seen going above
So let me stop you.
the
Let me stop you for a minute. So this is the and the AP projection and lateral projection of a single patient. This is a different patient. This is two different patients.
okay, 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 all right.
I'm sorry, I couldn't.
Uh,
I should have told you from the beginning.
yeah. NG tube, I can see the NG tube is in place, and the other one, it's the umbilical, as you have told that patient has undergone the umbilical venous catheter, so it's misplaced, and it is seen in the region of the right, in the right hypochondriac region.
Yes, excellent.
And it's likely in the portal vein, and it's so I would urgently inform the referring doctor, and this patient needs urgent repositioning of the a catheter, and it should be
Okay.
yeah, it should be at the level of that.
Let me just take over. This is a very difficult and a tricky case, but sometimes you may get confronted by they will give pediatric x-rays and ask if the catheter positions, you should be you should be aware of that. So you can actually see a thin catheter which is going here. On a lateral radiograph, it is very much evident. You can actually appreciate this. Just follow me. Follow my. Are you able to appreciate my cursor?
Yes.
So it is actually going into the epigastric artery. So this is an umbilical arterial catheter, which is actually going into the superior epigastric artery, which is actually malpositioned. Okay, you can actually see on the frontal radiograph, it is coursing towards here, towards the paravertebral region. But on a lateral radiograph, we can nicely appreciate malpositioned umbilical arterial catheter. So even in the exam, if you are not able to see they are not going to ask you an exact position. At least we can mention malpositioned umbilical arterial catheter. The next case also, you can actually appreciate the umbilical arterial catheter going here, but it's just going here. But on a lateral radiograph, we can actually see this course here. Can you see? Follow this course. It's going, and it's going into the renal artery or the renal system. So renal vessel, it is going in. So sorry, it's a vein, umbilical vein. So the right side, it is in the superior superficial epigastric vein. The again this case, it was in the left renal vein. So it is just actually malposition. It is going here, somewhere here, and here. That's the left renal vein. Okay, so you should actually there is this one a very illustrative diagram where how the umbilical artery and vein has to be placed. Umbilical artery catheter should be higher than the celiac and mesenteric renal arteries. So tip is somewhere at the T6 to T9 level. So that's the level which is expected for the umbilical arterial catheters. For the umbilical vein, the tip has to be positioned at the IVC level. So probably at the level of diaphragm. So diaphragm should be your landmark for a umbilical vein catheter. So most common malposition for the umbilical vein tip is somewhere it can get lodged into the portal vein or superior mesenteric or the splenic vein. Okay. So for a pediatric chest radiograph, so you look at the lung, look at the abnormal lucencies, and you have to be very careful. Sometimes gross rotational movements can mimic some sort of an abnormal pathology. And osseous abnormalities, look at the clavicles, the ribs, and also the humeral joints or the shoulder joints. And pulmonary vasculature, you should not see it at the periphery or up to you can get to see the pulmonary vasculature up to the mid two-third. It should not come till the periphery of the lung parenchyma. Then look at the costophrenic angles, look at the diaphragm. Sometimes in pediatric cases also you can get to see the thymus. So you should not give that as abnormal, and cardiac shadow has to be carefully evaluated. You have to carefully rule out congenital heart diseases, egg on string pattern, boot-shaped heart kind of pattern. So you have to be very careful. So these 4 articles are very good for the pediatric lines and radiograph, then radiologic assessment of lines and tubes for. So all those these articles are very good for pediatric lines and tubes. Okay. Any other candidates are left, or are we done?
Yes, I'm the last candidate, I think. Hello?
Okay, fine. Yes, you can take this case.
Okay, I'm
History
presenting.
of jaw pain.
Jaw
She
pain.
is a 23-year-old. History of jaw pain.
Okay, I am presented with orthopantomogram of adult patient presented with jaw pain. I couldn't appreciate a gross abnormality other than the tooth that's been displaced, the second premolar tooth on the right side, on the lower side, that has been displaced superiorly with underlying lucency as well. Another lucency is seen underlying the first molar on the same side. I'm looking for any well-defined lesions that had, because they could have been coding the displacement of the teeth. There's some lucency projecting below those 2 teeth. However, it's not well-defined.
So what is your differentials? What is your diagnosis? What will you do for her jaw pain next?
If this is like a floating tooth sign, I would be worried about ameloblastoma. Differential could include osteomyelitis or hyperparathyroidism. Less likely to be metastasis or multiple myeloma in this age group. So I would recommend doing maybe an MRI with contrast or a CT to further characterize the underlying lesion compared to previous, if any, available.
Okay. Fine. Let me just take over and let me just explain. Can you look at the cortical margin on this side, on the left mandible, quite sharp and very nicely outlined. Look at the right side, even though the margins are sharp, can you see these periosteal, sunburst kind of periosteal reaction?
Yes.
Can you appreciate? So this is actually a quite large soft tissue, actually, this one is. So unfortunately, the soft tissue is too much. I think they couldn't cover completely. But yes, so this was, we did an MR also for this case. So you can actually appreciate a large, a solid lesion, predominantly involving the mandible on the right side. So this was a case of a gnathic osteogenic sarcoma. So you have to refer this case to the tumor board and needs a multidisciplinary approach, including the surgeon, oncosurgeons, and the radiotherapist. All has to be involved in this case for the treatment part.
Yes.
All right. So probably our last case.
So I've been presented with frontal abdominal radiograph of a baby who is presented with failure to thrive and progressive distension of the abdomen. First, I could see there's soft tissue density projected over the left upper abdomen, causing some displacement of the bowel loops inferiorly. However, there's no gross calcification or differential opacities within this lesion. Okay, so I'm suspecting for a left upper abdominal mass lesion in a baby. My first differential could be if it's from the kidney, could be peripheral junction obstruction. If it's from the spleen, could be splenomegaly. Could be as well a mass lesion from the kidney, like Wilms tumor. However, it's not common in this age. The more common in this age would be a neuroblastoma. I would convey my findings to the parent physician and ask for further characterization of this lesion by ultrasound of the abdomen. And if there's any suspicion about this lesion, I would proceed further with a CT.
Okay. So let me just take over. So what you see here is a large, ill-defined kind of a soft tissue density, which is like displacing the bowel loops. So in a 2-month-old, so with this sort of opacity or a lesion, you should think of a neuroblastoma. CT scan was showing a large lesion, and you can see the aorta being lifted up. Lifted up aorta is a very typical sign of a neuroblastoma. Wilms tumor has to be your one of your second differential, but very less likely in age of 2 months, and it predominantly arising from the left adrenal gland, and it's been displacing the left kidney. All right, so you have to again refer this case to the multidisciplinary team, and then needs a further discussion on how the treatment plan, surgical with radiotherapy, surgical with chemotherapy has to be the next line of treatment. So actually someone asked me, I'm not sure whether I have given this diagnosis. So the diagnosis is gnathic osteogenic sarcoma. So that was a biopsy, post-biopsy proven case of the previous case. So to conclude, 3 rules to win the short cases. So step 1 is speed, but at the same time, even if you are at going very fast, be safe. And 4.8 minutes per case. So describe major abnormalities first, and don't get lost in the incidentals. And if you miss a major pathology, so you may not get through that case. So if in case if you wasting your time on a single case for a long time, you will press the panic button. So step 2 is use your template. If you are in that panic mode and you don't know the answer, flag that question and you can always come back again. So step 2 is use your template. You have to follow this. Describe the lesion, localize it, pattern, what type of pattern the lesion has. You have to give precise 3 differential diagnoses, and your next plan of action has to be there for every single case. You can follow this, and template beats the talent, where structure will give you a confidence. Step 3 is red flag first. You should always flag all those important emergencies, especially the pneumothorax, free air, fractures, malignancies. Spot it in 30 seconds on when it has to go on in your brain. So you cannot miss it. So some cases may be an exam breaker if you miss all this pneumothorax or red flag findings. So I trust your preparation, and I'm sure you all have got this exam at your backhand. So all the best to everyone. We're going to write the upcoming FRCR exam. So we'll conclude this session.